All right, good morning. This is Senate Health and Welfare. It's May 28th. We're looking at a bill that's been returned to us from the House, S-190, and this is a bill of our continuing work. We started working on this 2022 with Act 167, then we went on with Act 51, and then we went on with Act we got number 40 something, and then Act 68, most recently to have some oversight and control through the Agreement on Care Board of the highest costs in the nation for hospitals and insurance premiums. And so this bill is our next step in lowering those costs and lowering premiums, and at the same time making sure that our hospitals stay financially solid and sustainable. So this bill is something important to us in this room. And Jen, would you please help us go through? I know I've been through it with Jen, and I've gone through it myself, and I think it's important for the committee to see what changes have come back to us. This is a bill that we passed out of here early in the middle of the session, and had a good vote on the floor. So why don't you help us?
Great. Good morning, Jen Harvey, Office of Legislative Counsel. We are looking at S-190, and I think it's the same document as posted twice, so pick whichever one you want. But I have a version as showing the as passed by the Senate with the House markup. So
We each have that.
yes, you also have 197 floating around, the same thing. First sections are still reference-based pricing. The House added some language to the statute directing the board to use reference-based pricing to reduce hospital prices incrementally until they are equal to national median prices by hospital type by calendar year 2030, and to use the highest quality nonpartisan data demonstrating hospital prices as a percentage of Medicare to evaluate our progress.
So, and maybe remind us what we had if we had a different goal.
You did not have language
We didn't have a goal.
specific to this. I think this was recommended by a healthcare advocate and others in the House. So if you have,
Okay.
I'd like to refer you to Fisher. Then we get to the reference-based pricing, and for the most part, they did not make changes to what you did here, other than there's a date change for when the provider contracts between hospitals and health insurers need to be using a percentage of Medicare or another benchmark for items and services identified pursuant to a collaborative process between the Vermont Care Board and representatives of Vermont hospitals. Still keeps the language saying for both that and the hospital price transparency requirements under federal law should be shown as a percentage of Medicare rates. They kept language saying the hospital can use their own experience of Medicare rates as opposed, and until the Vermont Care Board adopts a rule establishing the methodology for using a standard benchmark. Also kept your language around the unique national provider identifier on the claims for claims delivered at off-campus departments in the hospital. One of the biggest changes in the House version comes from this idea of the limitations or caps on hospital reimbursements. And so the language you sent over was, and you'll see it later struck through because some of it was too complicated to try to show changes because it changed a fair amount. You had sent over limitations on hospital reimbursements for qualified health benefit plans for the QHPs. The House has done that and also added plans covering school employees. So I'm going to refer to these as the VHI plans. These are the plans offered through the Vermont Education Health Initiative, which is a health benefit association, which is where you see some of these terms. So the House sent you back limits on hospital reimbursements for QHPs and the VHI plans for hospital fiscal year 2027. And they have incorporated that Medicare adjusted base rate definition. They have the definitions of the qualified health benefit plans registered carriers and they've added school employees. And then it starts out by saying, notwithstanding any provision of, and there's this long statutory reference, that's really the language in the Green Mountain Care Board duties that requires them to adopt rules in order to do rate setting. And so they're in the process of working on their rulemaking for reference-based pricing, but they do not have it in place. So it says, notwithstanding any provision of the requirement that says rules are required to do rate setting, for hospital fiscal year 2027, the Green Mountain Care Board may order hospitals to reduce their commercial reimbursement rates for QHPs and for the statutory way of saying VHI plans, health benefit plans offered to school employees by a health benefit association pursuant to a provision in Title 24, establishing them as an intermunicipal insurance association. So notwithstanding any provision of you got to make rules before you can do any rate setting for hospital fiscal year 2027, the Green Mountain Care Board may order hospitals to reduce their commercial reimbursement rates to the QHPs and VHI plans based on a percentage of the Medicare adjusted base rate determined by the board for each item provided and service delivered in Vermont to enrollees in these plans. So you had sent over a 250% cap on the QHP on reimbursements to the QHPs. So this expands to QHPs and VHI plans, but it takes out the specific percentage as a cap across all hospitals and instead allows the board to determine the appropriate percentages for items and services at each hospital. It keeps language, so here's the 250%. Keeps language saying that the payers, so the carrier or health benefit association here, shall not reimburse or agree to reimburse a hospital more than the percentage of the Medicare adjusted base rate specified by the Green Mountain Care Board, if any, because it is a may, for the applicable hospital fiscal year for any item provided or service delivered in Vermont to enrollees in the QHPs and VHI plans. And it keeps your language saying if the reimbursement is done on a non-fee-for-service basis, the carrier needs to make sure its reimbursement method is adjusted to account for any reimbursement limit set by the board. It strikes the language saying the cap remains in place unless and until the board establishes a different reference-based price, because this is only for hospital fiscal year 2027 and it's not a fixed price across all hospitals. Keeps your language saying no balance billing. The hospital can't charge or collect from patients anything in addition and any more than the reimbursement amount, except for the cost sharing that's authorized under their plan. They kept this language, but because it sort of moved around, and I wanted to make sure you saw it was kept. They did keep language saying to the extent that a hospital is required by a budget order to reduce its commercial reimbursement rates more than the reductions achieved by any limitations imposed for the QHPs and VHI plans, the hospital shall reduce its reimbursement rates that are more than 500% of the Medicare adjusted base rate, or if they don't have any rates that high, then by reducing the commercial reimbursement rates that are the highest in relation to the Medicare rate. And then you had language that this keeps saying, Green Mountain Care Board needs to make sure that the limits on reimbursements are carried through into the premium rates for the qualified health benefit plans. This adds similar language for the Department of Financial Regulation, which reviews the rates for the VHI plans, saying make sure that the limitations on reimbursements are appropriately reflected. And then, so you had it in two pieces. You had the statutory cap for the QHPs in Title 33, and you had language in the hospital budget review provisions in Title 18. This is kind of combined into a single standalone session law provision that is only in effect for hospital fiscal year 2027. While the board is working on its rules for reference-based pricing more broadly. Any questions on this piece? So that's what you can see. No. Some of these questions taken out and moved. But it's great. Section 4, they struck, this was a report on implementation of reference-based pricing for certain public employee health plans. Just having the report come back on what it would look like to use reference-based pricing for the VHI and state employees plans. And because they extended reference-based pricing for hospital fiscal year 2027 to include the VHI plans, the House took out this language because it is anticipated to be implemented more broadly in future hospital fiscal years. What is now section 4 was your section 5, I believe, was hospital outsourcing. So they kept your report on having the agreement and care board, allowing the agreement and care board to direct hospitals to provide information about the clinical sources that they outsource, and having board report back to the legislature about hospital outsourcing and including any changes needed to the provider tax. Section 4A is new to the bill, but not necessarily a new concept. I think this one has been in the budget. And this is language authorizing the Department of Vermont Health Access, in consultation with Department of Financial Regulation, to submit a state innovation waiver under Section 1332 of the Affordable Care Act to establish a reinsurance program and to seek federal pass-through funding as allowed under 1332 waiver for amounts attributable to premium tax credits under federal law. What is now section 5 is language you had in your bill and did not change in the House on excluding the reference-based pricing from the scope of healthcare professional bargaining. No changes there. No changes to what is now section 6 on appeals of agreement and care board orders. For sections 7 and 8 on data infrastructure and the health system performance tool. No changes there. Section 10, the House struck the Public Employee Health Benefit Authority Study Committee. Wait a minute. So you are on page 15.
Oh, I'm way ahead.
So this is several pages of struck language.
Yeah.
The House in part was concerned. The Treasurer's Office estimated they would need, I believe, $350,000 to do the Public Employee Health Benefit Authority study. There was a significant financial request there, and House took that language out. So several pages of struck language. They made changes to the language you sent over on the critical access hospitals and the Medicare outpatient cost sharing aspect. And so the language you had sent over directed a working group to be created. There is already a working group happening, as we understand it from the Agreement Care Board. So it starts out with a little bit of background that the General Assembly and Agreement Care Board have recently become aware of this issue, that under federal law, Medicare beneficiaries must bear financial responsibility for 20% of the charge for outpatient services delivered by critical access hospitals, not 20% of the amount Medicare pays for the service. Recognizes that the General Assembly can't change this federal requirement, but also that it has significant impact on Medicare beneficiaries, and that Vermont's critical access hospitals are some of the state's most financially vulnerable healthcare facilities. And so it expresses intent to provide information to Vermont seniors and others about the federal requirement, while a working group tries to come up with solutions that don't undermine the financial sustainability of critical access hospitals and that comply with federal law. And so by September 1st, it directs each critical access hospital to do several things: to identify all of the outpatient services for which the amount the hospital charges equals 5 or more times the Medicare allowed amount for the service, to post prominently on their websites and in outpatient departments of the hospital a disclosure about the federal requirement, and that Medicare beneficiaries might be able to get care cheaper from other providers, and how to contact the hospital's patient financial assistance department for more information. And it requires the hospitals to file their proposed disclosure materials with the Agreement Care Board for approval before posting. And then you had language saying the board cannot do anything to address this issue in hospital budgets for fiscal year 2027. The House language does not include that. It instead says, to the extent that the board engages in efforts to address this issue in hospital fiscal year 2027, the board must consider any proposals from the critical access hospitals and others and ensure that its actions are consistent with ongoing hospital transformation efforts and the Act 48 principles. And then finally, we have the effective date would still take effect on the passage.
Thank you. It's good. Questions committee of Jen. So comments on the bill as it's come back. Doesn't seem vastly different from what we said over, taking out specific numbers and for the board to work with individual hospitals, which I think is probably, from at least from a hospital perspective, it's a great improvement. And I think in terms of providing sustainability for hospitals, it's an improvement.
Hear what kind of savings?
What kind of savings from this? Well, yeah, so you're talking about the QHP and the VHI. Right, so actually the board did a study on this reference-based pricing a couple of years ago, and the savings were significant in the millions of dollars. If you look at what Montana has done, where they put this in for their public employee, just the QHP, I think it's only the QHP market.
State employees, is that?
No, that's state employees, right? Montana was state employees. And they've saved over $40 million, like $48 million. So there's savings here. And what we're doing with this is looking at what those savings are and then directing the board to ensure that they're included in premium costs. So that we'll reduce premiums for folks who are purchasing on the QHP market. So those are little businesses and our individuals who may have some out of pocket and other expenses that are pressuring them economically. So there are savings here.
And the House version also includes the VHI plans. So that,
and yeah, if we had VHI in as well, then maybe another, probably slightly less because of the population difference, but so it would probably be, $34 to $40 million. We're looking at $80-90 million overall. You don't know until you start looking at how that all should have solved.
And there's a chance that folks who left the market because the premiums are so high will come back in.
That's a good point.
Expanding pool,
Yeah.
and so
Yeah.
it's a benefit all the way around.
We've lost 2,000 people. Any other questions? So I know there's been some discussion about this bill out in the hallway. And I see silence around the table, but there are questions about any components of the bill.
I think what's good, they improved it.
Yes, ma'am.
I guess my question is, we have limited, at least for the time being, the reference-based pricing to the qualified health plans. This bill expands it to VHI. I assume since there's a limited amount of money to be saved, that by spreading it out over a larger group, the savings go down from
To an individual.
one group, but I'm not. I'd like to know what that is. Do we spread it out so that no one notices it? Or do we concentrate it so that one group sees a noticeable site?
Well, it'll be a reduction for each of the services that each of those individuals seeks within the hospital setting. And so there'll be a reduction for each of those people. So if you're putting it into reduction of premiums, it'll be a reduced premium. I'm not sure I'm understanding your question.
Well, you could,
That'll be savings across the board. It doesn't spread the savings.
Okay.
Savings go right into the premiums. Yeah, so
If I understand Senator Cummings' question, I think it's if you have more people across whom you are spreading the savings, if you increase from just focusing on the QHPs to QHPs and VHI,
yeah,
and you have approximately the same amount of savings that you're taking out of the system.
You
Is
can
there
only
a-
take so much
Right,
out of
is
the
there a-
hospital.
oh, right,
They're
oh,
Spread
exactly,
out.
right.
I'm just wondering how,
What's the impact?
yeah, I mean, if it's a $5 reduction in premium for everybody, big deal. If it's a $500 reduction in premium, that is a big deal.
And that's exactly what the board will have to evaluate. And in addition to which, remember, right now, the board is writing the rules for the more expansive commercial market by 28. The entire commercial market will be in this environment. So this is a good opportunity to look at for the board to evaluate how to move those savings to Vermonters. All we hear about is property tax, property tax, property tax. And it's related very much to healthcare. Anyway. All right, other questions?
Are the majority of Vermonters in ERISA plans?
Yeah, so go ahead. I have the data. I think Nolan might have the data. You're talking about commercial market, 200,000 people.
Are in ERISA plans?
Yes, sorry. About that?
How many are in?
No, I'm looking at Nolan.
Yeah,
It's gonna correct me.
I can't remember off the top of my head, but it's a lot. It's a lot.
I'm just looking as to where the majority is.
It's a majority in the commercial market is, I believe, are for people in self-insured. Not necessarily risk, because the employees, for instance, are.
Okay,
No.
all right, but all those
They're all regulated by
self-employed.
ERISA. Some of them are self-funded and some of the self-funded we
Okay.
cannot regulate.
We can't make it.
But
So if you're looking at QHP market, individuals are a range of between 25 and 30,000. And a small group is about 40,000. So it's a total of somewhere, it's hard to get right now because the website at Diva is down. They don't have numbers posted, who's left, who's is still in, but somewhere between 70 and 85,000.
The record, all Island joint fiscal. It's roughly, if you look at small group, large group, sorry, small group, the individual market, and BHI, you're looking at about 96,000. To 97,000.
Yeah, that's what I mean.
Between the three, yeah.
Total. With those two, VHI, we're talking about including VHI, yeah, because that's about 36,000. All right, so committee, is anyone interested in providing further proposal of amendment to the bill to send back to the House? These are our choices for concur with the House proposal. Further proposal amendment, conference committee. So given where we are in the session, I'm not inclined to think. And I'm also thinking that the changes that have been made actually will facilitate the process because it allows for the board to work with individual hospitals. And there are some hospitals who are less able to do this, and that's important. So from that perspective, where we had the 250 and now the board has latitude, I'm fine with what they sent over, but I'm willing to listen to your need for a further proposal amendment. I guess as far as I go there.
There's no amendments.
Okay. So, let's just do we vote on this?
I think it's straw poll, you don't have it.
Yeah,
it hasn't
that's
referred
right.
To you, but you report.
Straw poll then. All those in favor of concurring with the House proposal on S-190, raise your hand. And I expect an explanation with any yay or nay votes. So all those opposed? And then I would ask you why you're opposed to it after we worked so hard and on this bill and you voted for it earlier.
I did go for it. I liked it earlier.
And why you don't like it now is because you've been approached by the administration?
There you go. No.
No, I'm serious. No, I'm serious.
No. No, I imagine the administration probably likes this bill, but I don't know. That's for certain. I don't,
Yes.
go ahead.
My perspective, and I've always been a little bit uncomfortable in that prevalence-based pricing still hasn't been figured out. And that was true. And that's something that still has to be developed. So the real implications and impact won't be known until kind of that's figured out. And as I recall, I remember suggesting that it be phased in with trying some area first and see how that works, and then adjusting as opposed to kind of diving in with both feet. And that's kind of my uncomfort level with it.
I don't think they were in the committee last year, but we took a lot of testimony.
Yeah, this is the problem. And reference-based pricing is a well-known entity, and including which there's a lot of contract negotiations between insurance companies and providers that include reference-based pricing. What our goal is to provide some predictability and uniformity so that we don't see these huge fluctuations and sort of that's it. So I think, yeah, it's unfortunate you've missed that baseline data collection that we had in the room with Act 68 in particular, but other bills as well. Well taken. Senator Morley, do you want to comment?
I just don't think this bill does much anymore.
Well, I think it does exactly what Senator Benson does. It starts gradual and moves in. So we'll see. All right, so I'll carry the message to the floor, and it will probably be on the floor today. And I'm gonna start from scratch. I'm gonna have to start from scratch and maybe talk a little bit about historically what we've done. But I think the bill is a good bill. It offers reassurance to the people who have concerns about their hospitals. It offers reassurance to people who are paying high premiums. It offers reassurance to our school boards and our districts where healthcare is a burden on property tax. That for me, when you're lowering premiums for people in the individual and small business market, and when you're lowering premiums for school districts that directly relate to property tax, I don't know how we can not support this, really. That's a bad message. Anyway, so understand your experience with this. But you have to have a little trust. Right. All right, so we've done enough for today. I have to go to another meeting, so we're gonna call it a wrap and go